Okay, so let's talk a little bit about OAEs, or otoacoustic emissions. This is actually going to be what, why, and how all together, because it's a very small amount of slides. This is nowhere near the in-depth level of information that you are going to need to know about otoacoustic emissions. It is my understanding that you're going to cover OAEs in more depth in one of your anatomy or electrophysiology classes. And in those courses, you will learn more about sort of the science and the anatomy and the mechanics behind OAEs. At this point, what I'm really interested in is understanding how to interpret them clinically and the clinical usage and application of OAEs, because they're used really frequently. So first, what are OAEs? OAE stands for otoacoustic emissions. OAEs come from the biologic amplifier in the outer hair cells. So the outer hair cells are long and skinny, and they have muscle types of proteins in the sides of them, and they are motile, which means that the cells themselves, not the stereocilia on top, but the actual cells themselves, expand and contract. So the outer hair cells get longer and shorter in combination with basilar membrane movement to allow us to have very, very fine frequency discrimination. And it turns out that when this happens, when the outer hair cells are actually expanding and contracting and aiding in the perception of sound, they emit a subaudible sound. What I tell patients is when your ear is working correctly, it actually emits a very soft crackle sound. And that's what the otoacoustic emission is. And if you use a sensitive enough microphone, you can actually detect that very soft subaudible sound. By using different stimulus tones, you can activate different areas of the basilar membrane, and thus the outer hair cells at different frequencies and at different parts of the basilar membrane. So you can get information about whether or not the outer hair cells are working as they should at different frequencies in different areas along the basilar membrane. There's two main types of OAEs that you're going to see. DPOAEs, which stands for distortion product otoacoustic emissions, and TEOAEs, which stands for transient evoked otoacoustic emissions. And there's this whole very long story about patents and copyright and this whole thing about who invented the OAE. The long and short of it is, most clinics you will see, with older equipment, you will see either the option for one or the option for other. It is only on much newer equipment that you will see the option to run either or both. And they differ in the type of stimulus that they use. So, DPOAEs use two simultaneous tones and are primarily measuring frequencies from 500 to 8,000 hertz. TEOAEs use very brief clicks or very brief tones, and typically measure frequencies from 1,000 to 4,000 hertz. TEOAEs are a little bit faster. DPOAEs give you the ability in many cases to measure more frequencies. Why are OAEs important? So there's a couple of things you have to understand. OAEs are not a direct measurement of hearing. They are a measurement of whether the outer hair cells are expanding and contracting. They don't tell you what sound is making it to a person's brain. They don't tell you if the sound is audible. They don't tell you anything about the health of the auditory nerve. But they're used really frequently clinically for a couple of reasons. And they're good tests. They have good sensitivity and specificity to different types of disorders. One thing that's really important about OAEs is that they're another objective test. there's so much that we do in audiology that is subjective. OAEs do not depend on patient response. Literally, all they need is the patient to sit there and be quiet and still for about a minute and a half. And so it can be really, really helpful to give supplemental information. They're easy. They're essentially just as easy as TIMPs. You're just going to stick a probe in somebody's ear. You know, the entire thing to test both ears can be over in 4 to 5 minutes. It can be used with all age groups. So again, as long as the patient is quiet, if you can get a toddler or an infant to tolerate to sleep or snooze or watch a silent movie and tolerate a probe in its ear quietly, you can get OAE results. This is particularly important with populations that are hard to test. People with multiple disabilities, young kids where it can be really difficult to get reliable behavioral testing information or reliable pure tone information. Infants and kids that are too young to do behavioral testing. OAEs are all people that you think may be malingering or exaggerating a hearing loss. OAEs are really important in all of these more difficult to test populations. There are some cases where OAEs may be more sensitive than pure tones to pathology. And so these tend to be cases where the pathology or the disease process or the condition is causing outer hair cell damage directly. So ototoxicity is an example. With aminoglycosides and carboplatin and cisplatin, which are the chemotherapy-based ototoxic drugs. Those drugs all affect outer hair cells directly. So in some cases, you're going to see that dysfunction may show up on OAE results before you see any kind of big change in pure tone results. The same thing can be true with noise-induced hearing loss. Where there's acoustic trauma, you may see it show up a little bit more or look worse on OAEs than on pure tones. So how do we do OAEs? Basically, you're going to stick another probe, just like the TIMP probe, in a person's ear, and that probe is going to have essentially 2 speakers and a microphone. And the 2 speakers are going to send different tone sounds in if you're using DPOAEs, because you need 2 simultaneous tones, and the microphone is going to measure the sound that's coming back out and is going to sort of cancel out the stimulus sounds and just look at the sound, the emission itself, the cochlear emission that's coming back out from the cochlea. So you have the red arrow is the simultaneous tones going in, and then this blue arrow is the otoacoustic emission coming back out from the cochlea. What you have to keep in mind here is, obviously, for you to measure an OAE, you need a functioning outer hair cell, but what you also need is a clear path to and from the outer hair cells, which means a conductive pathology can interfere with otoacoustic emissions. So anything that's stuck in the ear canal, anything affecting the eardrum or the movement of the ossicles, is potentially obstructing the measurement of the otoacoustic emission. And again, it doesn't necessarily mean that it's not there, but there may be something obstructing its measurement. So this diagram down here is actually another good sort of flowchart type of diagram, where you have 2 speakers putting sound into the ear canal. It's passing through the middle ear, the ossicular chain, and activating the outer hair cells in the cochlea. And it's causing this intermodulation product, which is another way of saying a distortion product. And that product is the otoacoustic emission, and it's working its way back out through the middle ear, through the ear canal, to the microphone in the ear canal. But what this should really help you understand is that ear canal and middle ear are very important when you're talking about OAEs, because any sort of disruption or obstruction in either of those areas is going to really make it difficult to measure an OAE. Again, it doesn't mean it's not there, but it will be very difficult to measure. The how of OAEs is pretty simple. Ideally, before the patient gets there, you're going to type in the patient data and have everything ready to go. You have to do otoscopy because you need clear ear canals, and you need to do TIMPs because you need to know what the middle ear status is, if the middle ear is normal. I put you need normal TIMPs here, and ideally you do need normal TIMPs. If you have something like a type A sub D or A sub S tympanogram, you can probably still do OAEs. If you have a type C tympanogram, whether or not you're going to get OAEs is going to be questionable. And it's always going to depend on how much the eardrum is moving and, and what the middle ear is really doing. That's a case where if you have a type C TIMP and you performed OAEs and OAEs were present, you could interpret that and correctly say the outer hair cells are working well in this frequency range. However, if you had a type C TIMP and you did OAEs and the OAEs were absent, you can't really interpret that because it could be the abnormal TIMP disrupting your OAE measurement, or the OAEs could truly be absent. So when your TIMPs are not normal and you run OAEs, you have to interpret the results with caution. For the OAEs to be measured, the probe needs to be placed securely in the ear. There's no pressure change, so it doesn't need a completely airtight seal, but it needs to be placed securely. If you can hear a lot of the OAE sound, the probe is probably not secure. And then you need to give instructions to the patient, something along the lines of, you're going to hear some tones or some chimes. I just want you to sit quietly while you listen to them. Because otherwise, especially if you've already done pure tone testing, the patient's going to want to tell you every time they hear something. And then you just run them. You run the OAEs. Ideally, you would run them twice on each side to be sure that it's a true response.